Hello everyone, sharing an interesting case of acute pain lower abdomen. A 32-year-old female patient reported with history of slipping down 6 to 7 stairs when she was climbing down with wet feet. She got bruises in her back and insidiously she developed acute abdominal pain which aggravated on movements. Defecation was excruciatingly painful. Ultrasound was done after 3 days because she continually had pain in the abdomen for which she was continuously taking painkillers. And on ultrasound, I could see a mass, echogenic mass adjacent to the left ovary, for which and transvaginal scan was done. The rest of the abdomen was unremarkable. So here you can see that this is a transvaginal scan. You can see the uterus, the left ovary, and between the uterus and the left ovary, echogenic mass was seen, which also showed some increase in vascularity. In a particular sequence, it showed a rounded structure giving the appearance of a dermoid, but on continuous scanning, I could see that this mass could open up very well and was connected to the bowel loop lying in the pouch of Douglas. So I took a video sequence, and here you could see that the bowel is peristaltic, the uterus here, the ovary here, and from this there is you can see this fat extending into between the uterus and the ovaries. Can you see this fat? And here you can see some fluid. I'll play the reel again. And here you can see the peristaltic bowel loop. And what you can see here is herniation of the fat in between the uterus and the ovary. And some fluid is seen at the site of herniation. So I came with a diagnosis of probably I'm dealing with a case of internal herniation of fat through broad ligament. I suggested a CECT, which is the investigation of choice, but patient being a doctor herself decided to be on conservative treatment for a few days before undergoing the CECT. So internal herniation is defined as herniation of a hollow viscera by means of a natural or unnatural opening within the peritoneal cavity. Internal abdominal herniation is a very rare cause of intestinal obstruction, and the incidence is less than 5% of all cases of intestinal obstruction. More than 50% of internal hernias reported in literature are paraduodenal. Less common types include pericecal, transmesenteric, Winslow, intersigmoid, supravesical, pelvic, and transomental. Hernias originating in the broad ligament defects are very rare, comprising 4 to 7% of all cases of internal hernias. So common natural sites of herniation could be left paraduodenal, it could be right paraduodenal, it could be through the foramen of Winslow, then it could be pericecal here, or it could be sigmoid mesocolon here, or it could be transmesenteric right here, or transomental, which could be right here. Supravesical and pelvic hernias could be at this place. The pathological orifice can definitely develop in the body, such as post-surgical and post-traumatic, which lead to transmesenteric, colomental, and transomental herniations. So if we talk about the broad ligament herniations, it is divided into three types: type 1, type 2, and type 3. The type 1 herniation is between the fallopian tube and the round ligament. Type 2 is between the fallopian tube and the ovary, and type 3 between the round ligament and the uterus. In this particular case, probably we were dealing with type 3 type of herniation. So this is not the case. This is not for this particular patient. This is just for describing how it happens in the broad ligament herniation. What you can see here is this is the round ligament. And what has happened? That the intestine has herniated through the round ligament like this and has landed into obstruction. So this is what happens in internal herniations. The patient got a CECT done after 6 days, after once the pain had replaced to almost 90%, and CECT revealed only fat inflammation in the pelvis. So the final post-diagnosis was it was probably a post-traumatic reducible fat herniation in the left broad ligament. The take-home message is internal herniation, though is a rare cause of intestinal obstruction, but milder forms can present with isolated fat herniation, which cannot or can be reducible. Differentials for rare cause, it should be considered as a differentials for rare cause of pain abdomen. CCT is the investigation of choice, and laparotomy is confirmatory. So, thanks for watching.